Good afternoon, good morning, and welcome everybody. We will get started in around a minute. We're just giving everybody the opportunity to get logged into the webinar. Great, I can see lots of people logging in, so we'll make a start. Good afternoon, good morning, everybody. Thank you very much for joining us today for this webinar brought to you by the Lung Cancer Policy Network, focused on care pathways for lung cancer. My name is Helena Wilcox. I am part of the team working at the Lung Cancer Policy Network Secretariat. I firstly wanted to thank everyone for joining today and also welcome and thank all of our speakers. We're really delighted to bring lots of different perspectives together to discuss their research and expertise in lung cancer care pathways from around the world. I firstly wanted to just do a couple of housekeeping points. You should have received a notification that the webinar is being recorded. The recording will shortly in the coming days be hosted and shared on the Lung Cancer Policy Network's website. If you want to interact with us in any way, please do so using the Q&A function. We will be monitoring that both for any questions that you have for our speakers, as well as any technical issues that you might experience, and we will be on hand to help. I just wanted to give a brief introduction to the Lung Cancer Policy Network for those who maybe aren't familiar with the network. So we are a global multidisciplinary alliance of experts from around the world working to eliminate lung cancer as a cause of death by making lung cancer a policy priority. The network has been in existence for just over 3 years, and we're very proud to be a global network of over 75 members from the countries represented on the screen, and around 25 organisations are forming part of that membership as well. Our discussions today will focus on care pathways for lung cancer, and this follows a report that the network launched late last year focused on optimising care pathways for lung cancer. So to introduce us to this really important topic, I'm firstly very pleased to welcome Deborah Montague. Deborah is part of the organisation Lung Cancer Europe and also founder of ALK Positive UK, which is a charitable organisation. And Deborah is going to be introducing us all to the concept of care pathways for those who maybe are less familiar, and also speak about some of Lung Cancer Europe's important work in this space on bringing in the patient perspective into these conversations. Deborah, thank you so much for joining, and over to you.
Thank you, Helena. First slide. So yes, I've taken the view from patients from across Europe. So first of all, I thought it would be useful to share what the definition of a care pathway was. And actually, when you Google it, there are many different ones. But I thought this would actually encapsulated everything that should be included in a care pathway. And basically, what we're talking about is a pathway that enhances the quality of care for patients, which should hopefully improve patient outcomes, reduce any safety issues, also increase patient satisfaction, as well as optimizing any resources available. Next slide, please. So just so that we're all on the same page, and also the use of care pathways where they've been analysed has shown an actual positive effect on clinical outcomes, and it also leads to improved coordination and collaboration and communication across the different specialities, and hopefully improve interprofessional relations. Next slide, please. So what do patients want from a care pathway? Well, Lung Cancer Europe, this is okay. Next slide, thank you. Lung Cancer Europe is an independent non-profit organisation that is an umbrella organisation that covers 26 countries across Europe. The UK is included, and has over 40 members now. And so we are able to ask patients and carers directly questions. And next slide, please. In 2022, we did exactly that around asking the questions around care pathways. And so we carried out an extensive survey across all the member organisations, and I believe we were close to 1,000 responses, so a good representation across Europe and the UK. So we're able to now have a better understanding of what is this current situation and what patients actually want as well. Next slide, please. So this report is also available on the Lung Cancer Europe website for anyone that wants to go in and look at all the the insights that were gained. But looking at the beginning of a patient pathway, you could see there's quite a variance between patients' first medical consultation and those being referred then onto a lung specialist. And that's quite a variance from 1 to 2 months to more than 12 months in some cases. There's also a variance once you see your lung cancer specialist to your actual lung cancer diagnosis. So again, that leads to poorer outcomes for those patients who are waiting longer. Next slide, please. Another insight that we gained was asking patients what they thought would be most useful in the earlier diagnosis. And you can see here, over 60% thought that screening programs would be useful, but also improving, if you look at the bottom, improving relationships between primary care doctors and patients. So there's the host of recommendations, if you like, that patients would like to see an improvement in to help patients go through smoothly the care pathway. Next slide, please. When you do get to see your lung cancer specialist, you then need to be given all the information to make an informed consent. And you can see here that only just over 52% actually felt that they had all the information they needed in order to make an informed consent, but they actually signed the consent form anyway, going forward with the treatment options. There's a lot of medical jargon still being used with patients, and also there aren't many conversations taking place with the actual specialist. People felt they were reporting back that they wanted more time with the lung cancer specialist. So you can see here, in terms of at the bottom, patient proposals for improvement. Number wanted all the treatment options available, the understanding the advantages and disadvantages, and also the associated potential side effects. And this is only going to get more as more treatments come online and are available for patients. Next slide, please. When it looked at patients' overall needs, because obviously it's much more than just the treatment options that you need, then a number of patients reported back that they felt that their overall needs weren't being addressed. And so they felt that there was a real need for more patients, or it to become standardized that patients would have access to a cancer nurse, and also longer medical consultations so they can discuss all their problems and they're asked about them. So many patients aren't asked about their mental health, and there's a very close link between mental health challenges and a lung cancer diagnosis. They also felt it would be useful to have a central point of contact, and we know that the patients who have that already find it incredibly useful. And better communication skills. It's a difficult subject, there's a lot of science involved, but they wanted it brought down to a level that everybody could understand. Next slide, please. So the report then goes into a number of good practices that the patients and carers who completed the survey felt there should be. And I won't go into them in detail. The slides will be available for you to have a look at. So next slide, please. But it does talk about, the time it took for the mutation testing to results to come through, up to 6 weeks. So, and all that time is without the patient receiving any treatment. Next slide, please. So there's a number of recommendations that came through. So, next slide, please. And it also does highlight here the need for improved communication between patients and the healthcare professional. The last piece that is covered within the report is a clear call to action that came from the people who completed the survey, I should say, and one of them was to implement a rapid referral pathway to reduce the time between diagnosis and treatment. We know that the earlier patients are diagnosed and started on treatment, the better the outcome for patients. So it was also a real call that they wanted improved information between and dialogue between the clinician and the patient, much easier to understand, so that patients were making an informed decision around which treatments. Okay. And then lastly, there was a clear call out for targeted screening programs to aid in the earlier diagnosis. We know that there's now a drive to implement screening programs, and this was recognised by the patients across Europe in 2022, and so now we just need to get on with that, so that the more patients we can find, whatever their type of lung cancer, the better their outcomes will be if they're diagnosed earlier. So that is a whistle-stop tour of the Luce report, looking at what patients want and the current situation with care pathways. And you can see there's a number of areas where we have a lot of work to do. So, but I just wanted to give you a flavour of those insights. So, last slide, please. So just thank you very much for being invited here today to share those insights with you, and I hope they will be useful in the discussions taking part going forward. Thank you.
Thank you very much, Deborah. I think it's really important. It was really important for us to have you share these insights from the patient perspective to really ground our discussions going forward for the afternoon. Lots of food for thought for everyone on the call, as well as some of those themes we're going to pick up in our discussions today. In terms of the format of the rest of the session, we'll be having two expert perspective sessions. The first taking a broader care pathway perspective and thinking about some of the challenges and opportunities from that overarching care pathway perspective. And then in our second panel, we'll be digging into a little more detail about some of the specific points across the care pathway with further panelists. And then towards the end, we'll be bringing everyone together to have more of a Q&A session. And I can see that there are some questions being popped in the Q&A box from our participants. So please feel welcome to pop your questions into the Q&A box throughout as they come to mind. And we will be monitoring that. And when we bring all of our speakers together in the second half of the webinar, we'll look forward to answering and putting those questions to our panel. So starting off on our first panel, an expert perspective looking at challenges and opportunities across the care pathway. So we're very pleased to have three panelists join us today from around the world, bringing different perspectives from their work. So we're very pleased to have perspectives from Anand Sachethanandan, who is the co-founder and immediate past president of the Lung Cancer Network Malaysia. Also, Zulfikar Otti, who is a medical oncologist based across the Townsville University Hospital and James Cook University and Icon Cancer Centre in Australia. And you've heard from Deborah Montague from Lung Cancer Europe and ALK Positive UK. Dr. Sachethanandan has kindly shared some pre-recorded remarks for us, which we'll play for you before then moving on to Zulfikar and Deborah's comments. So Dr. Sachethanandan will be speaking about his perspectives on why care pathways aren't currently commonplace around the world.
Hi, everyone. Thank you very much to the Lung Cancer Policy Network for the kind invitation to be part of this exciting webinar to look at the potential of care pathways to optimize lung cancer care. I think, we will all acknowledge that, it's there's never been a better time to provide care for patients with lung cancer. In that, we have witnessed tremendous advances in the diagnostic and treatment landscape for non-small cell lung cancer in recent years, from more widespread adoption of low-dose CT screening for early detection through to integration of artificial intelligence technology, as well as precision diagnostics with platforms like NGS to be able to identify actionable mutations, which in turn makes patients candidates for very bespoke oral targeted therapies. And of course, in recent years, we have seen systemic immunotherapies potentially game-changing in terms of the pathological response that it evokes, and that translates into better event-free survival and hopefully into overall survival. So all around, very exciting, realistic hope for the better for our patients. And I think it underscores the fact that cancer care in general and lung cancer care in particular, therefore, is very complex and very costly. And I think we all recognize that the optimal care for most patients often requires a multidisciplinary approach and often multimodality in terms of treatment. And, the treatment that we offer our patients and the prognosis for lung cancer in general is very much stage dependent. That means it's also very much time dependent. And this again underscores the importance of a timely diagnosis from the initial presentation through to definitive treatment. And I think this is where care pathways have tremendous potential to help provide a necessary structure and a platform for the delivery of high quality, evidence-based, consensus-driven, value-based healthcare. Care that is comprehensive and holistic, will cover the entire patient journey, from preventative strategies and screening through to definitive treatments for confirmed cases, right to end-of-life palliative care. And of course, help to provide a timely service and address the inequalities and inequities in terms of access to seeing the relevant specialists or getting the various sort of investigations. I think, care pathways still presently are not very commonplace, and there are a number of reasons for that. Firstly, I think it's still a fairly or relatively new concept, even for us as hospital clinicians. There is still probably a low awareness and a poor appreciation on the role and potential of care pathways to improve outcomes and optimize the delivery of services for our patients with lung cancer. And let's be honest, it will require a certain degree of effort to create, from all the different stakeholders in the patient journey and all the relevant specialists and allied health professionals to develop consensus and create and standardize a care pathway. And for that pathway to be functional in the real world, it's got to be agile, it's got to be adaptable, and to stay contemporary and to stay sort of relevant. And there's also a degree of uncertainty in terms of how do we implement such a care pathway. Often for policy to be effective, it has to be from a top-down, so perhaps at a national level, or even in a country like Malaysia, which is where I'm based at, there can be a lot of variation, geographical discordance and variation in provision of services or access to facilities. So perhaps it can be a regional sort of based care pathway. And, if I can just briefly share, in Malaysia, for example, we have a well-developed healthcare system. It's a dichotomous healthcare system that about 60% of the public access, the public sector, which is modeled on the National Health Service in the UK. It is free at the point of access. It is under the remit of the Ministry of Health. But as you can imagine, the system is overwhelmed with a large volume of cases. Consequently, we're looking at long waiting times to see relevant specialists or to get the necessary investigations or scans. The remaining 40% tend to access private healthcare, which is largely funded either by out-of-pocket payments or from medical health insurance. And hence a more timely service can be provided. So the time to treatment initiation or intervention is much quicker in the private sector. However, there is the issue of financial toxicity, and cost can be prohibitive. So I think in implementing any care pathway, we will have to be very conscious and mindful of how we, what sort of healthcare system you have in your own country, and even within a country, whether one is accessing private or public healthcare, to be able to sort of deliver meaningful, sort of realistic service. That's something that we need to be aware of as well. Thank you.
So whilst he wasn't able to join us today, thank you very much to Anand for sharing those remarks in advance. I'd now like to welcome Dr. Zulfikar Otti to join the panel. I think he is online and should be joining momentarily. So Dr. Otti has been doing lots of research in his location in Townsville in Australia, into care pathways. And I'd like to invite you, Dr. Otti, to share your opening remarks on your perspectives on the role care pathways can play in delivering a holistic approach to care. So what does the literature tell us about progress towards global implementation of care pathways?
Thank you, Helena. Thank you, Health Policy Partnership, for inviting me to talk, and also all the attendees today. So it's an important topic, and it affects large number of people across the world. And I think because in my experience as an oncologist in Australia, and I have done research on health pathways and optimal care pathways. So I'll talk briefly about my viewpoint in this. The key features of most of the lung cancer optimal care pathways is that it is very holistic and comprehensive, like what Dr. Anand and Deborah has mentioned. And the pathways cover all the steps in a patient's lung cancer patient's journey, from prevention, screening to diagnosis, treatment, and end-of-life care. And the main principles of health pathways is to promote patient-centered care, safe and quality care, and multidisciplinary care. I think these are the main factors which are main principles for any optimal care pathway. So like many other developed countries, Australia also has a national lung cancer optimal care pathway. And although it has not been implemented all over the country, but many centers have started to implement these pathways. And the optimal care pathways their guidelines are aspirational. So clinicians are not obliged to follow exactly what the pathways recommend. And every step of the optimal pathway outlines a nationally agreed best practice for the best level of care. So they act as benchmarks for health services and clinicians to achieve, so that their patients get the best possible care. So I did a review of the optimal care pathways, which shows that only a few countries have implemented optimal care pathways. And most of them are developed countries like Australia or UK, and many countries in Europe as well. While some countries like USA has a different health system, which is mainly driven by private health insurance. So their pathways are a bit different from countries which have public health systems or national health system services. And vast majority of people with lung cancer now will live in countries who don't have any optimal care pathways. And I think that is a very important issue now, that the Lung Cancer Policy Network and other groups will have to try to implement optimal care pathways in these countries. And some regional, as Dr. Anand mentioned, regional areas have their own pathways, especially in management pathways. The large hospital groups in the US or various health service districts have patient management pathways. So these are mainly based on saving money. But national health pathways like the Australian National Lung Cancer Pathway looks at the holistic care of the patient. And many studies have shown that, as Debra mentioned, it is a proven fact that care pathways like optimal care pathways improve patient outcomes, enhance clinician performance, as well as it's good for the health system. It saves money. But the big question is, how do we implement the care pathway at a local level? I think that is probably the most important challenge many of us face. So with this, we need more data, and we need to know where are our deficiencies and what all can be done to fix these deficiencies and improve the outcomes. And for this, all layers of health administration and all the clinicians involved in lung cancer care should support and promote implementation of lung cancer optimal care pathways. And I think there should be in every regional health service, there should be a team of clinicians who are ultimately responsible for implementing and for the ongoing sustainability of optimal care pathways. So that is my short viewpoint on the optimal care pathways. Thank you.
Thank you very much, Sulfika. We have a few more minutes before we move on to looking at some specific aspects of the care pathway. I just wanted to explore a couple of points that you raised in your introduction. So you said sort of it's about how to implement them in specific settings, in specific health systems. From your work in Queensland and Townsville, how do you think digital tools could assist with that?
Yeah, that's a very important question because I think that is what the future of most of the health pathways and care pathways, I think. So are you talking about telehealth or overall digital involvement?
Whichever aspect or both that you would like to speak to from your research and your work.
Okay, thank you. So, I think nowadays in Queensland we use like electronic referral systems, so called smart referrals, which has streamlined referral process well. So my main research was mainly in the referral pathway. That is, when the patient comes to see the GP and what all investigations GP has to do, and then how to properly refer a patient and where to refer. So these are the main areas of research which I have done. So these electronic referrals, so we have implemented the referral pathways in most of the regional centers in Queensland. So for lung cancer, it's called lung cancer referral pathway. So this is a online tool which helps the GPs to which is an online resource for the GPs, mainly to look at what all investigations have to be done and whom to refer the patient, etc. And it's available for all the GPs in the area online, and it's available at the clinic computer as well as in smartphones. And whenever a patient comes to see them with suspected lung cancer, they can access this resource and do the appropriate referrals. So that has been, and also this implementing these digital tools are well supported by the Queensland Health and the local health service. So that is been a big positive thing for implementing pathways in our area. And also, as we know, we have had telehealth, using telehealth for medical reviews and medical treatments for many years. We have been one of the pioneers in this field. So we have established a telehealth, like a tele-oncology system where patients, because we cover big area, some patients are living more than 1,000, 2,000 kilometers from the treating center. So they can be seen by telehealth and treated at their place of residence. So this saves quite a bit of time and a lot of travel, a lot of discomfort to the patient and the family. And also there is a telenursing initiative where smaller centers can administer treatment at their clinics. As well as we have also started the teletrials program, which uses telehealth to recruit patients for clinical trials, which is definitely another important aspect of lung cancer care. Thank you.
Thank you so much for expanding on that, Zulfikar. Deborah, I just wanted to come to you about there's a lot of work that you've done in the UK and with Lung Cancer Europe on bringing in the patient perspective on care pathways and overall lung cancer care. What do you think the sort of role for your kind of organisations is, and how can you be part of advancing the conversation on care pathways so that they're more available and there's more commitment to implement them?
I think in the first instance, patient organisations are ideally placed to collate the insights and the views of patients and their experiences. So both Luce and Out Positive UK do various surveys to understand the real world situation with patients and their time to treatment and then all the way through the pathway. So that's the first thing. We have access to a great deal of patients that can give us those insights. And I think we then have a responsibility to share those insights with healthcare providers and decision makers so that they are in the picture, and we are adding our voice to the other voices that say, we need to improve the whole package around lung cancer treatments and care. I think the UK is is achieved great things, over the recent years. And I think, as Dr. Anand said, the time it's perfect. There's no better time because there are more treatments available for patients. It's not that death sentence that that people thought. That there are now many options for patients. So again, it's important that we understand and we get patients through that process and that pathway as quickly as possible, because there are still too many being diagnosed at a late stage, and that overall impacts their overall survival and also quality of life. The further down the path, the lifespan of lung cancer, it comes with more problems. So again, I think organisations like Lung Cancer Europe have an opportunity to be able to raise it at a higher level as well, because we've got an umbrella perspective, and hopefully at a European level, change perspectives and guidance that would allow more countries to be able to work collaboratively, because it isn't easy developing care pathways. We know that. But the more we can collaborate, share best practice across countries of what's being done, we're talking about, Australian situation with telehealth. Yes, patients are now used to it since COVID, when everything went, to telephone consultations. They're now, I think, in a position to embrace even more opportunities, but we need to do that through highlighting the need for these care pathways at the right level.
Thank you so much, Deborah. We're going to welcome both of you back to our kind of overarching panel discussion with everybody towards the end in sort of 20 minutes or so. So we'll hear more from you and look forward to hearing more about your work there. For now, I'm very pleased to welcome further three expert panelists to join our webinar today. And we're going to be delving into some more specific aspects of the care pathway itself, sharing their insights from their research and the countries that they're working in. So I'll first introduce each of you and then invite you to share your opening remarks before moving on to some questions. So I'm really pleased to welcome Andrea Barondi-Kitts, who is a lung cancer and patient advocate with the Rescue Lung Society and a board member there as well in the US. David Baldwin, who is an honorary professor of medicine and consultant physician at the University of Nottingham in the UK. And Morten Quist, who is an associate professor and physiotherapist and a clinician researcher at the University of Copenhagen in Denmark. Andrea, if I could start with you, thinking about some specific points within the care pathway, could I invite you to explore with us the differences between palliative and end-of-life care, and crucially, how and why palliative care should be introduced at earlier stages of the care pathway?
Great. Thank you for the kind introduction, Helena. So I'm going to start by quoting definitions of palliative care and end-of-life care. Importantly, palliative care and end-of-life care are not separate functions. End-of-life care is part of the palliative care continuum that starts with disease diagnosis and it ends with bereavement care for the loved ones and caregivers of the person with lung cancer. Both require a holistic approach with a team that includes specially trained nurses, doctors, pharmacists, spiritual workers, and spiritual advisor. Palliative care is specialized medical care for people living with a serious illness. It focuses on providing patients with relief from the symptoms and stress of their illness. The goal is to improve the quality of life for both the patient and the family. This includes practical help, physical care, medicines, spiritual and emotional support. Palliative care is based on the needs of the person, not on the prognosis. It is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. End-of-life care, which is referred to as hospice in some countries, is a term used to describe the support and medical care given during the time surrounding death. This can be needed for hours, days, or months. Care is needed in 4 areas: physical comfort, mental and emotional needs, spiritual needs, and practical tasks. The family and caregivers of the dying person need support as well, with practical tasks and emotional distress. The main difference between palliative care and end-of-life care is that palliative care is given alongside and hopefully integrated with medical treatment of the disease, while end-of-life care is usually limited to comfort care without treatment for the disease. Early palliative care has been shown to improve overall survival, quality of life, and depressive symptoms for people undergoing cancer treatment, including people with lung cancer. It should be included starting at lung cancer diagnosis and integrated as part of multidisciplinary care. Receipt of palliative care has been shown to increase the use of end-of-life care. The World Health Organization recognizes palliative care under the human right to health. Unfortunately, many, including medical professionals and the public, confuse palliative care with end-of-life care, resulting in underuse of this valuable tool. Inadequate resources are another barrier to providing palliative care. The World Health Organization lists additional barriers to palliative care as national health policies and systems that often do not include palliative care at all, limited or non-existent training on palliative care for health professionals, and inadequate population access to opioid pain relief. Over 56.8 million people worldwide are in need of palliative care, but only about 14% are receiving it. So we have a lot of work to do to really integrate and make palliative care accessible to everyone.
Thank you, Andrea, for sharing that important distinction and some of the kind of challenges that we need to address. I'd like to now move to David to share some opening remarks as well, taking a slightly different tack. So I think Deborah picked up on this in some of her remarks about the sort of changing stages of lung cancer and a key challenge being its current sort of detection at a later stage. How can care pathways support earlier detection efforts and initiatives? And what's the importance and kind of role of care pathways in efficient referral and access for patients to the latest treatments?
Yeah, so it's quite a specific question, and I'd just like to sort of clarify first of all what we're talking about in terms of detection. I think we have earlier diagnosis as a sort of umbrella term, which could include, detection of very early stage disease, or people that are diagnosed slightly earlier in their pathway as they move through the symptoms. These are both very, very important in lung cancer, because if you detect patients at an earlier stage, then they're going to have a better prognosis and also better treatment options because of the stage of the cancer. But in addition, if you detect people earlier on in their symptomatic pathway, they are more likely to be fit. They're more likely to therefore respond to our improving treatment and are more likely to be eligible for that improving treatment. In the UK, about 45 to 50% of our patients are not eligible for treatment on the basis of their presenting performance status. Now, that's terrible because we've got such good treatment nowadays, and these people don't get it at all. So one of the ways in which care pathways can improve that is by accelerating the diagnosis right at the beginning when patients become symptomatic, by having a mechanism by which patients can access assessment, early assessment, and linking in the start of the pathway with awareness and help-seeking behavior, which can then get them to present earlier, and making access to the pathway very, very easy for patients. That's not really happening very well in the UK, and I don't believe it's happening all that well, particularly for the more deprived groups in many other countries. So that's something that can be fixed. Our own national optimal lung cancer pathway, which was developed in 2015, when we first developed this, I liaised with my Australian colleagues actually that were developing a similar sort of pathway at the time. The difference I think is we having a National Health Service have managed to implement the pathway in a much more comprehensive way, and it's become a mandated pathway which is comprehensive, so it covers the whole of the NHS. And I'm glad to say that both Scotland and Wales also have a national optimal pathway now as well. So this is really moving, and it's really surprised me how much enthusiasm there has been for this pathway. But the reason has already been stated. Lung Cancer Europe, people have said this. Patients get very distressed when they have to wait. We know now, we've got evidence that if you have a longer pathway, you come to harm, because you're either not fit enough to have any treatment in the first place, or you deteriorate during the diagnostic pathway and then become ineligible for treatment, or at least don't respond as well to treatment as you would have done otherwise. So I think these national, preferably national pathways, are really important to bring forward both potentially some patients to an earlier stage if there is very early recognition of symptoms, which actually weren't due to the cancer at all, but turn out to get you into the cancer pathway. And then you have your CT scan, and it turns out to be early stage, or at least for the majority of patients, those patients that have later stage disease are fitter and more able to benefit from the modern treatments. So I'm a real fan of, as you can probably tell, of the National Optimal Lung Cancer Pathway approach, having put a huge amount of work into the pathway and then the implementation. I'm absolutely delighted to have been invited to participate in this very important webinar, and also the very important documents that have been produced. So I hope I'll just stop there, because there's lots of other things I could say about this as an enthusiast.
We can come back to many of those things, I'm sure, David. Thank you. Just to conclude, opening kind of concepts and introducing some different ideas, I want to finally turn to Morten to tell us about the role of sort of rehabilitation services, in particular for those with advanced cancer, from some of your work with the Excel program.
Thank you, Helena, and thank you for the kind invitation from the Lung Cancer Policy Network. Well, I have to say that even though I'm talking about prehabilitation and rehabilitation, I'm looking at the more exercise-specific part of rehabilitation, still acknowledging that rehabilitation is really a lot of things: smoking cessation, social work, and so on. But I will start asking a question to the panel and to all the attendants. And how would you end your days? would you end your days lying down for the last months you're alive, or will you end your days standing on two legs for as long as possible? And that was actually the aim of how we produced our project, the Exhale project, which is a project for patients with advanced stage lung cancer. And well, the eligibility criteria was that you couldn't get your tumor surgically removed. Sorry. So what we do is we perform a 12-week exercise program, and people can, after those 12 weeks, participate as much as they want to, especially because we know that they will be on an ongoing treatment. And we also know that some actually had a quite sedentary lifestyle before they got the disease, and you just touched upon some of that, David. And therefore, it's really important to create a program where you can tick in and out to what you really want to do in this program. Of course, we will provide as much exercise as possible, and with that, we know we can get results. We have shown we can improve the cardiovascular function, muscle strength, reduce anxiety and depression. And therefore, this should be essential for all patients with lung cancer participating in programs like this. In the Scandinavian welfare model, you are entitled to at least 3 months of rehabilitation. And even though it's free in Scandinavia, we still have problems getting people into those programs. I know that might sound as a first world problem because in other countries, they don't even have a program. But just to say that we really have to push these patients into programs. When we first get them into the programs, it's often easy to make them realize how much benefit they will get from exercise. And well, and that's, of course, will end my preach for today, because I really think that what we have to take with us here is that a little is better than nothing. So if you can only do 5 minutes, it's better than 0 minutes. Of course, I will always argue that 10 minutes are better than 5 and so on. But it's really important that these patients get the impression that it has a benefit to be active. Thank you.
Thank you, Morten. Thank you, all of our 3 panelists, for introducing their sort of perspectives from their own settings, as well as some of those specific challenges and opportunities within the care pathway. I wanted to start, if I could turn to you first, David. So monitoring and evaluation and sort of producing those kind of key performance indicators for a care pathway. How are you working on using those in the UK to improve clinical practice and demonstrate the value and what care pathways are doing to improve on some of those key performance indicators?
Yeah, so we have been revising our performance indicators in the UK. And one of the performance indicators that we have in the UK is the time to confirmation of diagnosis. And that confirmation really includes full workup, staging, and ready to be treated. And the target is 28 days from the beginning of the referral pathway. And what we're seeing, because of the way that the pathway works, by doing a very early CT scan, is we're seeing that actually the 28-day target, as it's called, is working quite well for lung cancer. But as we predicted when the target was being discussed, we want to know whether it works very well for people with lung cancer as opposed to all referrals. And the snag is that it is actually excluding a lot of people from having lung cancer very early on. So that contributes a lot to the 28-day target. But the people remaining have still got the problem of being diagnosed on time, and that's where we struggle. And then, of course, the goalposts shift. So now that we have, with the way we work up patients, is we rely very heavily on the PET CT scan as a way of deciding whether patients potentially suitable for curative treatment right up to stage 3B. And we are thinking about that all the time, and PET scans are very important. the availability of PET scans in the UK is a challenge. That has been a change to the goalpost. We've responded by improving the number of PET CT scanners, but it's a constant struggle. And then the latest kid on the block, of course, is the waiting times that we have for full molecular analysis for biomarker testing to make sure people get the right treatment, the appropriately personalized treatment. And that, again, the amount of work I've done to try to push this forward in the UK, you wouldn't believe. And we're still struggling with these targets. So what we are doing with the national optimal lung cancer pathway is we're breaking it down into all its components at individual sites. And this is being helped quite a lot by industry partners, actually, but by actually looking at the data to see which are the pressure points in your pathway. There are some common ones like genomic testing and maybe availability of PET scans, but there are other things where you say, well, what's not working here? Where do you need, more people that can do lung biopsies, for example, or better access to prehabilitation, this type of thing. All of these things might actually be important in individual services. So it's not, there is a national approach, like trying to get the genomics people to get their turnaround times to the 14-day target that we now have. We have a new national optimal genomics pathway, which is part of the national optimal pathway to try and stimulate that process. It's about involving all of the different policymakers and people that hold the power to make a change. And that's what we're trying to do. But it's not a simple matter of saying we've got this one pathway, we monitor it in the same way. We have to be dynamic about it and ensure that we're measuring the relevant things. But just and I think the other thing is you always have to remember that there's a patient in the middle of this. It has to be done with good informed consent about every single test. That's often not done. It has to be done according to the wishes of the patients and their ability to take this in. So it's all predicated on that discussion with the patient and what they want. It's not us just sort of saying you're going to have this bundle of tests and just get on with it. It's a proper discussion, or it certainly should be, and that's very clear in our pathway. I sometimes think that people are implementing the pathway sometimes miss that bit out. And just because they're so enthusiastic about getting people through rapidly, but you do have to remember that you've got a person there at the end of the day, and that's the most important thing.
Thanks, David. Andrea or Morten, did you want to add anything to that from what David's brought to the table?
The only thing I would add is that right now, the International Association for the Study of Lung Cancer, we're preparing some sort of recommended overarching quality indicators that are recommended for lung cancer screening. So hopefully having a recommended set that should apply globally will help everybody across the board to really, at least on the lung cancer screening side, and that would include the time to referral, and that'll be important for getting people into the actual care pathway.
Thank you, Andrea. Morten, is there anything that you wanted to add?
Well, I just, and of course I will continue preaching here. I think it could be really important when we do this screening that we add some sort of an objective measurement of physical capacity. I mean, at the moment we use performance status, and performance status does not even get close to saying anything of the change that could be in the performance status of these patients. So as David mentioned in his introducing talk, sometimes we will find patients that are not physical, I can't find the right word, sorry, but they're not physical fit to do surgery or actually getting immunotherapy or chemo. And therefore, already during the screening, we have a chance to actually change that. So, well, I think it's one of the low-hanging fruits.
I agree with that. I think that's a great point.
Well, I mean, one of the things that we've had in our pathway is we have a target time to finish the pathway, as in to say start treatment, which is not the finish of the pathway, of course, but it's the diagnostic and initial treatment pathway, 49 days. Interesting, the Australian National Optimal Pathway is 42 days. So, but as I said, the issue is implementation, and we have a phenomenal problem with capacity. But having a simple, worldwide agreed time to treatment as a maximum time would be phenomenally helpful for all countries. So what you're saying, Andrew, is absolutely right. You know, that we need to have one or two really good, you know, figures that people can say, oh, this is the worldwide standard. And there's good evidence for this. You know, we've got, once you look through the data on time to treatment, there are about 3 papers that get rid of this concept of sicker, quicker effect, where the sickest patients have the latest stage disease. They're easy to diagnose. They diagnose quickly, and then unfortunately they die because they've got the most aggressive disease. If you look at the 3 papers that I'm aware of that look at this for both early stage and mid stage disease, there's a really clear and actually quite large effect of relatively small weights down to 2 weeks or certainly a month in earlier stage disease. So we really have evidence for this. It's harmful to wait. And there would be, I think it would be very useful to have a global figure, just 1 or 2, key figures, and then it's up to you how you get there. But these are the key figures.
Yeah, and I think adding prehab into the pathway is really important. I mean, I haven't seen it in a whole lot of them. I'm involved with a PCORI study with City of Hope. It's a multi-institutional study in the US where we're taking a look at both prehab and then continuing, exercise. It's a walking program for people who are having lung cancer surgery for early stage lung cancer. And, if we could come up with, a program that would be sort of a general program, but individualized. And I think you've got that, Morten, and really make that part of the lung cancer pathway. And as soon as, someone is, even before they're officially diagnosed, when it looks like they have, like a LungRad's Cat4 scan, or equivalent in other systems, start talking to them and start thinking about the prehab pathway.
Thank
We
you.
already have the programs. I mean, we need to implement them.
Yeah.
This feels like a good time to bring back Zulfika and Deborah to kind of join this slightly broader discussion, sort of for the next 20 minutes or so. If I can invite you both to join. And actually sort of several questions that we've had coming through from the audience. I think they're sort of both responding to some of the points you've raised, but also maybe furthering the conversation a little as well. I wanted to start by asking a question from an attendee around, several of you have referenced where there are care pathways, optimized care pathways, or parts of a care pathway that do exist. From your perspectives, what have been some of the main deciding factors for take up or implementation in those countries? And for the countries where that's not the case yet, what do you think some of the main challenges are? I don't know if anyone is particularly wanting to jump in first. Otherwise, I can invite someone to start. David, I'm sure you've got some thoughts to share on this.
Well, I think there's several things here. It's about ensuring that there's education of the people that need to be involved in implementing pathways, because the first thing is there's an awful lot of nihilism, still there, an awful lot of nihilism about this, whether it's important or not. I mean, everybody's seen distress of patients when they have to wait, but somehow that seems to be something that's or sort of expected. That's not acceptable. And certainly there was a study in a very brief survey in Manchester that said, given the fact you've got suspected lung cancer, how long would you expect before your diagnostic tests are completed? And 50% said 1 week, and 90% said 2 weeks. We're nowhere near that, but that's what patients expect. And it's terribly distressing to explain to patients that they've got to wait 2 weeks to have a bundle of tests, which is what we do at our first appointment. So there's that. But also, I think one of the things that I've said that at many of my implementation lectures, in around the UK, was we've all heard, you're speaking to a bunch of clinicians and you say, we've all heard this, haven't we? When you're assessing performance status. Oh yes, I could do this, or if they're talking about their relative, he or she could do this 2 weeks ago. Well, that was 2 weeks ago. And that was when they were performance status 1, and now they're performance status 3. And we see that, as clinicians, we see that all the time, and everybody nods when you say that. So that's just giving an example of trying to get to the people that will implement this. And then, of course, there's the issue, if it's a national policy, you have to think about how you influence the national narrative and thinking to point out that this is a good thing. And you do that quite a lot by saying, if we do this, we may well meet your targets that you set yourself. So if there's a target there, that's always a useful thing. What I've been astonished by is how many of the lung cancer teams have taken the national pathway and said, initially, this is impossible. We can't do this. And then a year later, they're all trying to do it. So if you've got something that's national, some sort of thing there for people to grasp and adhere to, you've then got to get the belief going, which is about explaining the evidence and bringing up some practical examples, and then you're halfway there. And I think that's the challenge for many countries is having that process. And it can be done locally or it can be done nationally. It's for us in the National Health Service, it's easier to do it nationally. But obviously in other areas, it will be more of a sort of site-specific thing.
Well, for me, I found it shocking, quite frankly, David, when you said that 45% of people who are diagnosed with late-stage lung cancer are not fit enough to undergo treatment. That's a huge number of people. And I think we need to look at those kind of data to help influence and really get some of the patient organizations involved with this as far as, pushing it from a patient perspective, because that's totally unacceptable.
And that was I've just looked it up actually because I'm doing something else, but it's 2018 National Lung Cancer Audit data, and that was the proportion of patients that were performance status 2 to 4. So clearly some of the performance status 2 patients might be eligible for treatment, but we do know that performance status 2 patients don't do that well with treatment, compared to 1 and 0. Most of the drugs that we have in the UK are only licensed for performance status 0 and 1.
Oh, really? That's
only a few are licensed for 2, because most of the studies haven't included many performance status 2 patients in them. So that's the weakness of the evidence. So yes, if you take it just 3 and 4, you still got nearly 28% of patients are performance status 3 and 4 at presentation in the UK.
And that's the same in Australia as well. A lot of people don't get treatment because they are sick by the time they are seen by an oncologist.
Now, in the US, we don't really, do treatment by performance level. I mean, the drugs are approved, and then it's really up to a decision between the patient and their oncologist as to which treatments they receive. And even if they have a poor performance status and they want to try the treatment, they try it. Now, if they get too symptomatic, et cetera, then they'll be taken off treatment. But it's interesting to me that in other countries, it's more limited, and patients don't get the treatment even if they want it.
I think also there's an issue, sorry, David, there's also an issue around stigma and patients delaying going to their healthcare professional with symptoms. There's many public health awareness campaigns that have been carried out in the UK, highlighting what the symptoms are, and many patients just choose not to go and see the healthcare professional. I think there is now there's a misunderstanding about what can be done. That lung cancer there's an inevitability about the outcome where there isn't, and so there's a lot of public awareness that we still need to do around that actually lung cancer isn't the death sentence that it maybe was years ago. And we still need to remove the stigma that it's not, anyone with lungs can get lung cancer. And so, you need to present as soon as you've got the first symptoms. There's a lot of work still to be done on that in that area as well.
Yeah, I agree. And I think the other thing is that people need to understand that, chemo and some of those other treatments, they hear horror stories about how bad the side effects can be, but we need to really now tell them, well, no, we have palliative care. And people think palliative care is end of life care. So they're like, no, I don't want to see that specialist. But we can make a lot of difference with palliative care and relieving the symptoms and really improving the quality of life and the outcomes for the people with lung cancer. So that's another piece of the education and awareness campaign we need to add in.
Absolutely, that we need to be talking end of life and palliative care separately, even though they're part of the continuum. I accept that, because patients don't. They hear palliative care and they think, oh, they're putting me on the scrap heap because they're saying there's nothing more to be done.
Right.
And we know that that isn't the case. But it's hard to get that message through. We spend a lot of time in the ALK organisation trying to educate patients that, you know, they start getting side effects of their treatments, neuropathy being one, you know, and we say, well, you know, you should ask to see the palliative care team, and they're like, no. You know, we spend a lot of time educating, but there's a lot of general public awareness education that we need to do around lung cancer, so that more people come forward earlier. And also, I agree with the exercise piece. So many patients would benefit, even those with a mutational, you know, that aren't smokers. They would still benefit from exercise programs and keeping them. People don't realize their lungs are a muscle. And therefore, you know, in a way, then they need to be treated like that, and so that they, you know, they keep us fit as well for as long as possible.
And I was surprised that the nihilism is, even the doctors have the similar, a lot of doctors, including GPs and specialists, have that nihilism about lung cancer. So they don't even refer patients to oncologists because they believe there are no good treatments. I think education of doctors is also a part of the process.
Well, if you have the care pathways and make sure that when those symptoms are there, that there's an automatic referral, then that will help standardize and make sure that, you know, we address that nihilism on the part of the medical providers as well.
That's true.
Morten, did you want to come in or add to any of those points at all?
No, I'm just thinking, because I always hear this about rehabilitation and palliation, and sometimes we call it palliated rehabilitation, or we call it rehabilitated palliation. Maybe we should just stop calling it other things that lung cancer care instead. I mean, it's so obvious that some patients, they do like this when they hear the word exercise, because I've never exercised my life and I'm for sure not going to do it again. And others will react when we say, listen, you have to go to our palliative team and they can help you with some of the issues you have. And they say, no way, I'm going there. I'm not there yet. So maybe we should educate, I mean, the whole professional healthcare team in what these patients are capable of. Every time I'm talking about what we do in our project and our program, I'm always getting told that your patients are probably in a better status than our patients. Our patients are not capable of that. And when we started that in 2008, that was the oncologist and surgeon in Denmark saying that. Then they got on the wagon. Then we went out worldwide telling that. And every time I tell it in a new country, they tell me, well, you have to remember Scandinavians are more active than the country we are in. So we need to educate, just like we heard before, we need to educate our healthcare professionals that these patients are actually living a life when they are not at the hospital. And the better we can help them. I mean, some are, of course, in a poor shape, but others actually do have, let's call it, a normal life at home. And yes, they get to the hospital and they get some treatments that make them sick. And they are in a position where they are against an oncologist or surgeon or nurse or physiotherapist, and they will always be looked at as the victim, the patients that are not capable of anything. So I mean, my message is that we really have to look at these patients, and we have to educate the whole professional healthcare team so they would know when is the right time for palliation or rehabilitation or whatever we should call it. And then not that we are giving false hope, but some of these patients would love to be active a bit themselves, because that's is something they can do themselves.
Yeah.
I mean, getting treatment is really passive. If it's on the rehabilitation or palliation or whatever. So doing things you are capable of yourself, and maybe that will do that you could be on the floor playing with your grandchild or something like that, instead of lying in the bed and the grandchild is coming to you instead.
Yeah. I totally agree with that. I mean, what we have is we have a person with lung cancer, not a lung cancer patient. I mean, it's totally different. And I'll just say, I personally think that both palliative care and rehabilitation, I love, and physical therapy and all that should be, together in one umbrella, and it should just be automatically referred at the start of at the start of diagnosis. You're diagnosed, that's one of the referrals you have. David talked about a bundle of tests. Well, one of the things on there is you're going to get a physical. You're going to get a recipe for a prescription for your physical exercise. You're going to get a referral to the specialized palliative care team. That's just normal standard list of what you do when you get diagnosed with lung cancer. And I'll say, my partner has metastatic prostate cancer, and, he has a life. We have a life together. And yes, we're going to treatment. Tomorrow is chemo day every 3 weeks, but our life does not, revolve around that. He's a person with cancer, but he's living his life and just has to get this treatment on the side. And, because he's been fit and exercises, he's been able to withstand this with some challenges.
Yeah, I mean, our National Optimal Pathway has in it, in the bundle, that the patient receives medical optimization, they receive rehabilitation where it's indicated, and all stage 4 lung cancer, they have a palliative. We don't call it palliative care, actually, we call it supportive care in the UK. Interesting how things vary, but it's exactly what you're saying. The palliative word is not used very often now, in my experience, my own experience. It tends to be supportive. So it emphasizes the fact that we're trying to ensure there's a maximization of quality of life, and also response to treatment if they're eligible for treatment. So, and then there is also mandated a referral to the lung cancer nurse specialist who meets the person at diagnosis, or sometimes before diagnosis, to really tidy up all of the confusing elements of the pathway and explain to patients what's going on and how they manage to get through this increasingly complicated process. So that's all there. That's all in the pathway. It's getting it implemented is a challenge, of course, but it is right there. And it's, I mean, the pathway is now on version 4. So, we've had a lot of stakeholder involvement right at the beginning, and then ongoing modifications according to how the service changes.
Yeah, and patient navigation is key to this. I mean, really having that patient navigator navigate the person through the pathway. That's the only way it's going to really work from the patient and caregiver side. That's probably one of the most important elements of the care pathway.
Thank you all. I feel like I didn't need to moderate you, because I just really enjoyed listening to your discussions. I'm conscious that we're coming to sort of the last 15 minutes or so of our time together today. And I think you've all, raised sort of lots around your perspective of some of the key actions. I suppose I'd like to draw all of that together by inviting each of you in turn to share a sort of final reflection on what, from your perspective, would be a priority for optimizing care pathways where they exist, or sort of priority actions for actually implementing them in settings where they're not currently in place or fully designed. I wonder if I could start with you, Zulfikar, on that question.
Yeah, I think that's an important topic. So, well, my viewpoint is that so there should be ongoing research on implementing care pathways, including optimal care pathways, and find out how do we improve the implementation part. And we all know that there are standardized pathways like the Australian lung cancer pathway or the UK National Health Service pathway. But the problem is, how do we implement them for each and different types of health services and regions? So I think there should be ongoing research on this. And also in Australia, we're going to have lung cancer screening program started next year, which is going to make a big a shift in the number of patients who are diagnosed early. So I think the care pathways should be modified to address these changes as well. I think in the future, I think there will be more a role of artificial intelligence. So there has been a lot of research on using artificial intelligence in early diagnosis and screening programs. I think that is probably what I think would make a big impact in the next few years. So, for example, we talked about the navigators. So if there is if they use artificial intelligence for care coordination and navigation, so I think it will be much cheaper as well as more efficient to coordinate care of these patients, as well as for getting things done on time. I think probably that is my view. So using more digital tools as well as artificial intelligence is going to make things much easier and cheaper to implement.
Thank you very much. Deborah, perhaps I could turn to you with the same question, please.
If I look at it from a patient perspective, I think it's around general public awareness of what systems are out there, and also for GP education. I think if GPs had more lung cancer education as part of their program standard, then I think that we would find more advocates at that level that would push forward for as well locally to implement care pathways. I wish there were more Davids around the UK, then it would be great. But they're not. We haven't found out how to clone him yet. But we do need more advocates, and that's the bit for me is because if you've got someone with a passion in this area, then they will drive that local implementation. And I just wonder whether having a greater emphasis on GP education and then being more aware of where patients are currently getting stuck or delays in their presentation, that might help.
Thank you, Deborah. I'd also seen a couple of queries in the Q&A of how people could get in touch with Lung Cancer Europe, so we'll make sure to connect you after the meeting. Morten, can I come to you with the same sort of question for the future and your final thoughts?
Well, I think one of the most important things is that we will start to look at these patients with some new eyes. I mean, so for instance, the performance status now it's a subjective measurement done by the physician. We need to have a specific test to kind of have an objective measurement for physical fitness, because that is the only thing where we can change things. It's really difficult to go from a performance status 1 to 0, but it's quite simple to exercise and improve your strength or improve your cardiovascular function. So I think we need to look into how we look at these patients, and of course during the screening there's not many with my eyes that look at the patient. So in my future site, I would hope that more physios or physiologists could be part of this and trying to look at the patients with a different set of eyes.
Thank you. Andrea, could I turn to you next, please?
Sure. I mean, for me, it's all about making sure we have multidisciplinary care. So I agree that we need advocacy to get the policymakers to say, okay, it's time to implement this lung cancer care pathway. But we really need to make sure that we include all the disciplines involved. That's not just the medical disciplines, but it's all the social workers, the social determinants of health. It's exercise, it's supportive care. I love that term, David. And I think if we started from a multidisciplinary level, get all of those stakeholders involved, we've already got examples of care pathways. We can just take David's care pathway, and see how we can, or the one from Australia, and see how it can be modified and implemented in each country. But we really need to have, as Deborah said, the passion around implementing it from the patients and the multidisciplinary team, and then put it in place, and critical elements to me are, the lung cancer screening for early detection, patient navigation, and multidisciplinary care, including all disciplines, not just the medical ones.
Thank you, Andrea. A really important point to sort of get towards the end of our webinar. So David, we'd asked you if you could sort of spend 5 minutes or so on closing remarks sort of the whole session, and any thoughts you want to leave us with. So perhaps in the interest of time, I could maybe ask you to roll that together with your thoughts on that final question as well, and give you sort of give you the floor for the next 5 minutes or so.
Okay, well, I probably shouldn't take that much time, but first of all, it sounds like a bit of a horror movie having clones of me walking around. But in fact, the whole implementation process has to be run by a lot of different people, and it's a bit like having a guideline. If you spend 2 years working on a guideline, if it's then not used, you've wasted those 2 years. So the implementation, in my mind, is equally important to the actual thought that goes behind the development of these tools. So I think first of all, the fact that we're having this webinar and this conversation is incredibly important, I think, and it's one of the things that I think has been something that has been a bit slow, actually, to be fair. I mean, I think the ISLC are now addressing this. This group are addressing this. It is high time this was done, because it is really, really important. Everyone has said this. The patients' surveys say it. The individual people that have experienced cancer themselves say it. It is absolutely an important priority in lung cancer. It is most important, I think, in the more aggressive cancers, the ones where you've got a limited amount of time before people become too unwell to benefit from the treatment that we have now. And now, of all time, now we've got such good treatment. There's an imperative to get this right, to actually start this conversation in all countries, and then allow at least then the individuals in the country to see how much progress they can make by demonstrating that other countries are doing something differently. So, and I think there are many different pathways there now in lung cancer that can be shared, and that people can then use that as a resource. I think it would be really helpful if we had, as we've already discussed, top line targets for the maximum amount of time that anyone should expect to wait before they can be offered treatment, given all of the complexity. But there should be something like that written down so that we can go to that. We've just to share with you a bit of what we've been doing, trying to get our genomics stuff sorted out. We've been pushing really, really hard for a 14-day turnaround time from acquisition of sample to full molecular analysis. And it has taken, years that we've got to that. We're nearly at the point now where the document will be published. But until the document's published, no one really knows about it. And therefore, you've got genomics centres working to 21-day turnaround times, which are not meeting. They don't know anything about the 14-day turnaround time. For example, you have to make sure all of this is advertised. So I would say that what we've got here is excellent support for all of the things that people that develop these pathways already have cited as their reason for developing the pathways. And as you saw from the question online, in Sweden and Denmark, they have a whole host of pathways for all different tumor sites. So it doesn't just benefit lung cancer, it benefits other tumor sites as well. And we have, I think it's 14 now in the UK of these timed pathways. They're very different from the National Optimal Lung Cancer pathway, but it's very, very important. And I think the other thing that can be learned that we probably haven't mentioned so far is the implementation tools that lie behind the pathway as well. So in the UK, we have our pathway document is 24 pages long because it has things like how you investigate and work up and what tests you do in what order for stage 1, for stage 2, stage 3, etc., according to the local guidelines. It also has suggestions about how you can make this an electronic system so that the tests are all automatically requested when you plug into that particular stage of cancer, for example. It has we have a number of tools that measure the points in the pathway that to see how it's being implemented. I think all of these things are secondary things that we could develop, and I think the Health Policy Partnership is in a perfect position to make sure that benefits the global community as opposed to just individual countries. But I think what I've heard today is a group of people that have said things that resonate, that none of which I disagree with in any way. I mean, it's like an amazing, level of agreement here that we seem to have come to, and I think that in itself is phenomenally encouraging. This is a good thing to do. It's reasonably evidence-based, and patients will inevitably benefit from this, so psychologically and physically. And I think we should just do all we can to try and push this forward.
Thank you so much, David, for rounding off those discussions. Sort of very clear opportunities for next steps and how to take this work forward, both at the national level and as you suggested, at that global level, and how to bridge between the two as well. Just in the last few minutes, I won't add too much to David's very apt conclusions of the day, but I wanted to firstly thank the panelists on the screen, so David, Morten, Andrea, Deborah and Zulfika, and Anand for sharing his remarks with us and perspectives in advance ahead of time. Thank you very much for the work that you do and for taking the time to spend an hour and a half with us today. Thank you very much to all of our attendees today. We've seen your questions and I fully appreciate we didn't have a chance to go through all of those themes, but please be assured that we have captured your questions. We will make connections where you've asked us to do so, and we will look forward to taking this work forward. One of the sort of main reasons that I alluded to at the beginning of bringing together this group of experts was that the Lung Cancer Policy Network last year launched its report looking at lung cancer care pathways, exploring the essential role that we've discussed in detail today that care pathways play in optimising and delivering best practice lung cancer care. You can access the report using the QR code on the screen and all of our other resources and policy recommendations from the Lung Cancer Policy Network, all available on our website. And if you'd like to speak with us further about any of the topics that we've talked about today, or any of our work, then all of our social media channels and other ways to get in touch are available on the screen. So once again, thank you very much to all of our speakers, all of our attendees, and I hope everyone has a good rest of their day. Thank you again.